Thank you again for joining us here for this workshop. It's going to be very, very interactive. My name is Josephine Munene, a founding member of the Kenya Association for Breastfeeding. And we are here with the sole goal. Our aim is to make sure that we are able to create very strong linkages between the community through the community health worker and facilities when it comes to lactation management and support. I know we all keep hearing breastfeed for 6 months exclusively, continue for 2 years and beyond, but how do we make sure that mothers get the practical support in addition to the knowledge to be able to fulfill all these goals? So welcome, it's going to be interactive. Please be prepared to do some group work. They can see some papers on the wall, so this is not sitting and snoozing. I know it's after lunch. So we are going to make sure that we are able to move around. No snoozing for this one. Thank you.
Thank you. Good afternoon, everyone. My name is Mili, Karina, and I'm also a founding member. I'm a nurse midwife and a lactation consultant, and I know full well the gaps that we have in the community with regards to being able to support the mothers in a timely manner. So today's session will be ensuring that we empower the healthcare worker and all those who tend to meet these mothers out there in the community, how to be able to support them with the basic information that we'll share. We will ensure that you leave here feeling a bit more empowered. Yes, it is after lunch, so we will try and make this the interaction as interactive as possible. Thank you.
Thank you. And my name is Esther Kimani from the Kenya Association for Breastfeeding, and I am a nutritionist, an infant and young child health nutritionist. I'm a childbirth educator, a doula, and basically I support parents through their pregnancy and in the first parenting period. And so it's so exciting to see all of you. And we just want to do a little pointer because we want to see just how much knowledge do we have? Where are we coming from? As my colleague has said, how do we start from the process of helping these parents actually come from the theory of breastfeeding and into being able to be successful in their breastfeeding journey? And I just have a few questions, and you just lift up. As you said, it's very interactive, and so you can just lift up your hand. It's a true or false, and then we see. So, is it normal for breastfeeding to hurt? True or false? Is it normal for breastfeeding to hurt? True or false? False, eh? Okay. There's no way to tell if a breastfed baby is getting enough milk. True or false? False. If a baby is fussy after breastfeeding, mom should give a bottle of formula. True or false? Breast size matters.
False.
False. Breastfeeding makes the breast sag.
False.
Is it true or false? Let me hear from the gentleman. True. So my baby just had teeth. I think I should stop breastfeeding. True or false?
False.
If a baby becomes more demanding, a shibi, an alia, they are crying all the time, maybe I should give some uji. True or false? And they are not yet 6 months.
False.
Your mother was not able to breastfeed you. So I think you will also have problems breastfeeding. True or false?
False.
Breast formula is just like breast milk.
False.
I'm asking wengine waki. Not sure. Babies need a bit of water. False? True or false? Okay. If a baby weighs more than 3.5 kilos, you might not be able to have enough milk for that baby. True or false?
False.
You have twins. There's no way you can exclusively breastfeed. True or false?
False.
Fantastic. I think we are starting from a good place. And so I'll invite my colleague, Mili, to take over. She'll take us through a little session and we'll move from there.
I think I want to move around. That's fantastic. I love that you have a lot of that information with you. Again, my name is Mili, and I will be taking us through this brief presentation on empowering primary healthcare workers for better child and maternal health. As I said, I'm a nurse midwife. I tend to support, educate, and empower mothers even through their breastfeeding journey. And this is even before the baby comes, how to help them prepare better for the lactation process. Now, if you want to find us, our contact details are there. We are doing this workshop in partnership with LactaHub and Kenya Association for Breastfeeding. So welcome, please indulge us with your attention and interact with us as well. So it's important to look at the benefits for breastfeeding. Many times we focus on the benefits for the baby. We know that they're gonna get good immunity, they'll grow better and stronger and even faster, but we also don't focus as much on the mother. So it's important to go through these list of benefits. So for sure, it has been proven by research that breastfeeding will lower your risk of breast and ovarian cancer. It will also cause you to lose weight and you go back to your pre-pregnancy weight. It will lower your risk of osteoporosis. There are studies that have conflicting evidence. There are those that support about the osteoporosis being reduced. Others feel that it's still high, but there is some evidence that it is reduced. Bonding. This cannot be taken away from any mother. The bonding that the mother gets just holding the baby, cradling the baby in her arms is something that she cannot compare with anything else like bottle feeding. It saves money. Formula is expensive, so you give formula. Now, because this baby is not getting the micronutrients, the antibodies to fight the disease, you end up going to hospital more often. So you add that on top of the cost of buying the formula. And there are many other added costs on top of that, such as even buying medication for this baby who's probably having gastritis issues. So if you're exclusively breastfeeding your baby, it will save money. Involution of the uterus, that just simply means as you're breastfeeding your baby, you're producing oxytocin, which is the hormone that will help reduce and shrink back the uterus back to its original size. And then it has a reduced risk of postpartum depression. This is proven that mothers who choose to breastfeed have a lower risk of postpartum depression. Now, if we go to the baby and we look at some of the benefits for you choosing to breastfeed your baby, or for these mothers we are supporting for choosing to breastfeed their babies, it protects against allergies and eczema. Many babies who are put on formula tend to get allergies to the milk, the cow milk protein. That's a very common one. End up getting eczema and other skin issues. There's also a less incidence of stomach upset, diarrhea, constipation. If you choose, for example, diarrhea, you're using formula. These mothers maybe don't have access to clean water. So the water they've used has not been boiled. They didn't use proper hygiene when preparing the formula. These babies actually get diarrheal diseases. It reduces a mother's risk of a UTI, bowel disease, GE, ear infections. Now, what is so interesting, babies who tend to bottle feed or are mostly on the pacifier, it increases their ear pressure. The way they suck on the pacifier or the teat, which makes them more susceptible to getting ear infections compared to babies who are not on a bottle. SIDS, which is the sudden infant death syndrome, when they compare and see the babies who are experiencing SIDS and those who are not, those who tend to experience SIDS actually are bottle fed. It protects against meningitis, type 1 diabetes, and some lymphomas like Hodgkin's lymphoma. It does increase your baby's IQ. Did you know that? Breastfed babies are actually smarter. Their IQ is a lot higher. It helps prevent obesity, and as well as the mother, the bonding and attachment that is there is amazing. Now, if we look at the anatomy of the breast, there are many things here that are involved in lactation, which is milk production. We don't only focus too much on the areola area, which is the dark area behind the nipple. We also want to see the alveoli, the ductules and the ducts which end up just behind the nipple where the milk comes from. We have the ligaments supporting the breast, and a major one is the Cooper's ligament. Then we also have the fat tissue. Yeah, and all these alveoli, they form the lobules. So that's just a picture, an image that looks at internally what the breast looks like. The stages of lactation. Stage 1 is mammogenesis, and it starts really early. Mammogenesis starts with the fetus at between 4 and 5 weeks. The fetus gets milk lines that just come from the breast area all the way down to the groin area. Now, this is where the mammary glands are developing. And what is so astonishing about the organ, the breast, is that there is no other organ in our body that changes in size and in functions as the breast. It changes a lot. Now, when we move from mammogenesis, the puberty, the breasts are developing, we go into lactogenesis 1. And this is the initial phase of milk production, which starts when a woman is at 16 weeks pregnant, all the way until she's day 2 of postpartum. That is lactogenesis 1, and it's an endocrine process, so it's run by the hormones. When we move from day 2 to day 3, we get into lactogenesis 2. And this is an autocrine, supply and demand. The mother breastfeeds, the more milk she will produce. So it will increase the volume of milk depending on how often she's putting this baby on the breast. Then we go to galactopoiesis, which is long-term maintenance. So for however long this mother decides to breastfeed her baby, the milk secretion will continue on demand. So if she wants to choose to breastfeed her baby for 2 years, it will continue up to 2 years, and it can stop, I think, 40 days past the day she stopped breastfeeding. Now, it's important to understand lactation, the physiology of lactation, and how breast milk production happens. 3 things are needed for milk production. Many times mothers think that they need to drink milk to make milk. True? Is it true or false? That's what they think, but is it true or false? It is false. Mothers do not need to drink milk or a cup of milk every day for her to make milk. That is false. You need these 3 things. You need to have your baby, you need to have your breast, and the brain. So if you imagine a triangle, these 3 B's are well connected. So the baby, it comes to the breast, attaches well to the breast on the areola, and as they start to suckle, they stimulate prolactin, which will then stimulate the posterior pituitary gland to produce oxytocin. And the mother will tell you she feels a tingling sensation, a pain in her breast. It's a subjective feeling, but some sensation is felt. But actually, not all mothers feel that sensation. And then milk production starts to happen, and you begin to hear the swallowing of the mother. So it's a loop. If you can look at this loop, it's a loop, or even a triangle, which is a positive feedback loop. So if the mother is stressed, she's anxious, she's worried. Now think about the B for the brain. It will affect the production of milk. If the other B for baby is not attached well on the breast, the baby is nipple feeding and not attached on the areola, then the milk production will not happen. They might get the milk that is there. They're using the nipple as a straw, but they will not stimulate enough milk for the baby. Now, if we talk about the types and benefits of breastfeeding, we have colostrum, which is the first milk you produce. Again, it can start to be produced very early in pregnancy and lasts about 3 days. And we've talked about lactogenesis 1. Then it moves to transitional milk. So it's a bit yellow, creamish, not yet fully white. And this is there until day 10. Now, once you move from transitional milk, you go into mature milk, which is the white milk all mothers are looking for. But it's important to note, there is, in that mature milk, we have hind milk and we have fore milk. Fore milk is higher in volume with water. It has a lot more water and it has a lot more lactose, but less fat. But the fore milk, as the baby continues to empty the breast, and the breast becomes not as full as it was when it had the fore milk, the baby gets hind milk, which is a lot of fat. It's lower in volume, so it's not as much, but it has a lot of fat. Now you can see the differences in the milk through these images. Colostrum is very yellow, very viscous. It's actually quite thick, and it's very difficult even to use a breast pump during the first few days to get that colostrum through. So hand expression is what we would recommend. Now, these two combined are the mature milk. But if a mother is expressing her milk, you will notice the difference between the two, the foremilk and the hind milk. Now, many times mothers give birth and they think they will feel a full cup of milk on day one, which is a lie. It will never ever happen. The milk comes out in droplets because of the stomach size. The size of the baby's stomach can only accommodate 5 to 7 ml per feed, which is like a teaspoonful, to feed the size of that grape. 3 days later, it almost doubles in size and becomes 22 to 27 ml. She still cannot feed a full cup of even 100, 200 ml. By week 2, the stomach is the size of an egg. So always encourage moms that don't worry. They'll even tell you, nimaji natoka. Natoa tu maji. That's the start of colostrum, which will then start to change in color, become thicker, and that is what they need for day one. So we're not going to encourage mothers to give their babies milk 30 ml. Sometimes they say that the mother doesn't have milk, so let's supplement this baby. That is too much to give this newborn. Now, positioning at the breast. This is super important. Mothers need to learn how to position the baby on the breast so that the attachment is adequate. Now, the first one is cradle position, and Esther will show us how to do the cradle, which is the normal way we know how to hold this baby. But that is not the only position that we have. Thank you. So that's the cradle position. You put the baby's head on the crook of your arm, just opposite the elbow. Then we also have the cross cradle hold, where you hold your breast with one hand and the baby on the other hand, and you're supporting the baby's neck and holding your breast with the other hand. Once the attachment is okay, you don't have to continue holding your breast. And if you can notice how she's holding her breast, she's using the C hold. We don't encourage moms to do the scissor hold, yeah, because you end up blocking the areola. They only take what's in between your fingers. Most times is the nipple. So 4 fingers under, the thumb on top, or the U hold, which is the other way. Never like this, unless the mother's nipple is shaped in a certain way, depending, but majority do the C hold. Then there's the cross position. If you have twins, you can actually breastfeed them at the same time, which is called the cross cradle. It's like the rugby hold. It's also called the football hold. Mothers can also breastfeed lying down. This position does not need to be discouraged as long as the baby is facing the mother when they're lying down. Then it is possible to do that position. Now, if the way she's done the cross cradle and the cradle hold, what I need you to notice is that the baby's tummy is fully facing the mother. Sometimes you'll find the baby's head is facing one direction and the stomach is looking another direction. That's not a good position. There need to be some alignment where the ear, the shoulder, and the hip are in a straight line. The same way we eat, we don't eat with one side of our body facing this way and we're eating this way. We face our food completely, so should the mother. Now, there's this thing of saying tummy to tummy. So the mother imagines the baby is really low. Okay, they need to face the tummy, but it doesn't have to be low. Bring them right up here. If they cannot hold the baby throughout the feed, then you can use the cushions. And then, yeah, I think those are the main positions that we would do. And the underarm position for twins and even for one baby, which looks very common, like the cross cradle, very similar to the cross cradle position. So there are very many positions the mother can use, not just the one. Now, how do you know the difference between a good latch and a bad latch? So if you can see the good latch, most of the areola is in the baby's mouth. You're seeing the top part of the areola showing, which is the dark area of the breast, but the bottom part is covered. Also, the chin must press the lower part of the breast. Compare the good A and the C. The chin is very far. The chin on A is touching the breast. That should tell you that's a very good latch. Actually, the latches are asymmetrical latch. The baby will be able to get enough milk from A and B, but from C and D, the baby is biting, almost chewing on the nipple. It's very uncomfortable for the baby, for the mother, because they have very sensitive, cracked, sore, even sometimes bleeding nipples, and the baby will feel like they're not getting an adequate amount of milk for them. Now, we need to think about when we're supporting these mothers in terms of breastfeeding. I want you to remember this acronym, BREAST. We would need to observe the position of the baby, the body position, the baby's responses. Are they calm? Are they crying? Are they turning away from the breast or seeming interested to breastfeed? Emotional bonding should be there. The anatomy, how is the breast? Is it flat? Does it have a flat nipple? Does it have an inverted nipple? Does it have a cracked nipple? What does the anatomy of the breast look like? Is there sucking happening or there's no sucking happening? And about the termination of the feed, you also need to observe how does that happen. Is it happening too fast? Has the baby been latched on long enough and you feel like they've had a good feed? So I want us to play a video that will help you to counsel a mother in terms of how she's being able to attach the baby on the breast, and you as the healthcare worker can be of good help just even observing and counseling where you need to. So let's have a look at this video and then I'll come back. Just the little key or basics that you need to look out for to counsel the mother, and also never forgetting that you need to praise her and tell her what she's doing well. And you saw the little things of even undressing, take off the blanket so you really see how the baby is positioned. Are they positioned well? You know, and letting the mother do most of the work. Because as healthcare workers, we know as midwives, you want to come and put the baby on the breast for the mother. But when she goes home, she struggles because she's not been doing it for herself when she's been in hospital under your care. So always empower the mother to be able to do it on her own. Now, there are mothers who struggle. There are challenges when it comes to breastfeeding. There are not many, but they are there. This is a list of some of the problems that mothers may encounter. Having sore, flat, so a flat nipple does not protrude, and an inverted nipple goes inwards, it doesn't protrude outward. So what is the solution for this? Still, it is possible to breastfeed with a flat nipple or even an inverted nipple. You're going to use a breastfeeding aid, so it could be the nipple puller, or which is a replacement from the syringe. In hospital, they tend to give a mother a syringe to pull out the nipple because it's flat or inverted. Now that is very painful. We have something that we use. It's called a nipple puller. It is so much more gentle than using a syringe to pull out a nipple. So it's something, a really simple gadget. You squeeze it, they put it there, and it attaches. It pulls out the nipple for the mother. It is not painful at all. But I've done the same thing with a syringe. It is excruciating. And the syringe also causes a friction burn on the nipple. Now, if the mother is having low milk supply, it can also be a challenge. Remember to review the baby breast brain. So you're looking for the attachment and positioning. How is that going? For the brain, mentally, is she okay? If she's stressed, she's not resting, she's anxious, she's in pain, it will affect her supply. Is she feeding often or not often enough? Has she structured her breastfeeding time where she's saying she's only going to breastfeed every 6 hours as opposed to on demand? That you would need to change and encourage her to breastfeed more often, or remove the milk by using her hand expression or a pump. Now, for fussy baby or a gassy baby, also review the attachment, because if the attachment is shallow, we saw the baby who had a shallow latch and was making that sucking sound. Breastfeeding is usually quiet. All you should be hearing is the swallow, the gulp, but never the sucking. If you're hearing the sucking, the baby is taking in a lot of air, and it will cause your baby to be gassy. Also, it could be reviewing the mother's diet, because what she eats, the baby also gets it through the milk. So if there's something she's allergic to or gives her gas, then maybe she should put it away for some time, and then after the baby has developed a little bit, after a month or two, she can introduce it back to her diet. And then engorgement versus mastitis. Engorgement is a full breast, where it's so full, you're also actually not being able to extract milk. Mastitis, on the other hand, is an infection on the breast. Now, there are protocols that have changed in terms of how we used to manage mastitis. Does anyone know how that used to be done or is done? Mastitis? What was being done was doing very deep tissue massage on the breast. Were we using hot water or cold water? Excruciatingly hot water on the breast, but that is no longer being done because it makes the mastitis worse. You're supposed to use cool compression, so ice packs on the breast, no hot water. You're supposed to use very gentle massage, never deep tissue. You're supposed to rest the breast, as opposed to telling the mother, pump the milk out of your breast, keep emptying your breast. You're overworking that breast, it needs to rest. And under the care of your physician, you will be put on anti-inflammatory. So it's very different now. So we are supposed to avoid pumping excessively.